Okay. We're doing chemo drugs, so that is two chapters. Basically, it's 45 and 46. One is just basically 45 is part one, 46 is part two. Otherwise, it's basically the same information. It's just too big to put into one chapter. So that is, it's going to be all chemo drugs. Okay. Um, any questions there? Okay. Then I think we are good. I'm going to bring up the first PowerPoint and share my screen. All right. Please ask if you have any questions. Okay. So I have this right here. When we talked about, or sorry, when you originally talked about cancer and beginner med surg, can you tell me what you remember?
What I remember is that I want to say the chemotherapy can recognize which cells, so it will attack the good cells with the bad cells.
That is very correct. Yep. Yep. What is
And
our workaround for that? What is another option to attack just the chemo cells or the cancer cells?
it's a medication.
It's a type of medication. It's not a
A-
medication.
It's it's like a targeted.
Yeah. Targeted or immunotherapy. So kind of like the ones we've been learning about, right?
Yeah.
Okay. So that is an option. What else do you remember about cancer in general?
How it can spread.
Okay. How does it spread? Or what about any specifics about that or just that it spreads?
Know that it will start. I forgot what it's called, but it will start in one place and then it can spread to like the lungs, the prostate, and uh,
Anyway.
the, anywhere. Yeah.
Yeah. Yeah. And then what is it called as it how do we judge its spread? What is that called?
Metastasizing.
It is
Metastasis.
it is called metastasis or metastasize, but how do we actually like measure it or label it? How much it's spread? This has anybody heard of cancer stages?
Yes, it's the cancer stages.
Yeah, so that would be your like stage one, your stage two,
I think we went over that in like med surg one.
one. Yeah, okay. Med Surg 1, Meds is part where we do teach the cancer stuff. So I'm just going over that briefly here. So let me just go over a few things. Okay. So there are a few different things that differentiate a normal cell from a cancer cell. Um, a normal cell has the ability, let me go back to my little whiteboard thing here. Um, It'll let me see my, can this go away so that I can see my screen? Thank you. Okay. So ignore this for a second. If we go up here, all right, a normal cell is able to do the following things here. So they are able to have programmed cell death. What does that mean? So this is for a normal cell. All cells should be able to do this.
The lifespan.
Yeah, so like with the lifespan, it should be only able to live for so long, right? Either like so many days, so many weeks. Because why do we want our cells only to live like red blood cells, right? They live for like 120 days. Why do we want them to only live that long? Why do we need programmed cell death?
The function of the cell degrades over time.
It does. The function of the cells degrades over time, and then how do we fix that? We replace it with a new one, right? Okay, so when that happens, does that happen like throughout my whole life? That replacement? Okay, and then when I get older, Does it continue to happen? What's going on when I get older?
It slows down.
It does slow down, and then that's why I tend to see what?
Decreased function.
Yep. Okay. That is why I would see decreased function of all of my organs, right? The liver, the kidney, the heart, everything, the skin. All right. So that needs programmed cell death. So basically it's genes, my DNA, right? All of my cells have DNA, right? They're all supposed to die at different times, depending on what type of cell it is, right? That is programmed. It is regulated, right? So at the blood cell at 120 days, it's gonna die. It's programmed into its life. Okay. We good there? Okay. The next thing that a normal cell does is that it has a shape. Every cell has its own particular shape. So like skin cells will have a different type of shape, color than a liver cell. It is defined. Okay. Make sense there? Also, they should all have their own function. Okay. So every cell should have its own function. Because again, liver cells aren't going to do the same thing as red blood cells, right? So we each need them to do something different and to do what they're supposed to do. Because what happens when they don't do what they're supposed to do? Then the body's not going to work, right?
Yeah.
Yeah. Okay. Perfect. And then they all have, like, they don't spread. All right. So your cells should stay where they're supposed to stay. If it's a liver cell, it's supposed to stay in the liver. If it's a red blood cell, it's supposed to stay, in the bloodstream, right? It shouldn't be going places where it shouldn't. Okay. So these are pretty much the big functions that all cells have. Okay. Are we good with this? So when you don't have this, all right, then you go up to having your malignant and your benign. All right. These are going to be my two types of tumors. Okay. So what's the difference, the basic difference between a benign and a malignant?
One's cancer
One.
causing and one isn't.
Yes. One
The
is
malignant one has uncontrolled growth.
Yes, you are correct.
And no definition, like no shape, no definition.
Yes. So let's go. I like what I'm hearing. So let's go over it a little bit more here. All right. So a benign cell, okay, basically everything's the same except for the fact that it doesn't have this programmed cell death. All right. So it is going to, the bad thing about this, all right, is that there's no programmed death. All right. And with that, there's also no control on its replication. So what does that mean, no control on its replication?
It will keep multiplying.
Yeah, it's just going to keep dividing, right? What is the process called where it divides? Not asking for a deep explanation, just a name.
Is it proliferation?
No. It's mitosis. You remember hearing about that? Okay, so what is mitosis? How does that work? Just briefly. One cell copies its whole entire self, right? Makes double the parts, and then the other cell kind of morphs from that one, and then the old one dies, right? Does that make sense? Do you kind of remember that? Okay. So there's, in this case, with a cancer cell or a benign cell, there is nothing stopping it from not like, for like that one cell after it replicates, there's nothing stopping the other one from dying. Because again, there's not that programmed cell death, so it's just going to keep dividing and dividing again. Okay. Does this make sense? Okay. Then you're going to end up with your tumor. But again, when it's benign, it's going to keep. So let's say it's a tumor of a benign tumor of the liver. Okay. It's going to keep the shape of the liver cell. Okay. It's going to keep the function of the liver cell. All right. It's not going to spread. All right. Because tumors that are benign are encapsulated. So they have like a border around it. Okay. So they kind of have like, I'm trying to think of like an example. Like if you had a backyard, right, and you had a fence around it, right? The fence is going to keep it all in the same location, right? So nothing can spread outside the fence. So this is kind of similar. It has its own borders. Uh, all right. It has like a membrane around it that's growing. Okay. So it's kind of like that same tissue. Did I freeze? Okay. It's like that same tissue is going to keep dividing and dividing, but that's really all that it does with benign. Okay. Questions there? And then when we have malignant, okay, that is going to be my cancer, right? What is this one going to do? We said that it's going to spread, okay? So this one has no borders, so it just goes, it just keeps spreading. It doesn't have anything that's going to keep it contained, okay? Also, it has no function and no shape, okay? So let's say it's cancer of the liver cell again. These particular cells are going to have, they're not going to look like a liver cell. They're not going to do anything that a liver cell does. All right. All they're going to do is just replicate and spread. Okay. They will literally have no other function. Okay. So what's dangerous about this is as that tumor spreads over the whole liver, now your liver is filled of cancer cells that don't do anything as opposed to liver cells that carry out the liver function. So what is that going to lead to in my liver in this example? Anyone want to answer that one?
You gonna start to have liver failure?
Yeah, why? Because I don't have any liver cells left, right? It's going to destroy my liver. So does that make
Yeah.
sense how that happens?
Yeah.
Yeah. So, and then if it spreads to other organs, it's going to do the same thing, right? So that's kind of how you start to have all these issues with the cancer. Okay. So this one also has no programmed death, and it's going to keep replicating. All right. But what we like about the benign is that it still does the function and it doesn't spread. Okay. So that's why this one is safer. All right. Does anybody have any questions about the normal cancer cell, or sorry, the normal just cell in general, the benign or the cancer cell?
What's the difference between why benign cells form versus like the malignant cells?
Yep. So the difference how they happen is they both form from a genetic mutation. Where is that genetic mutation happening? In the cell's DNA. All right. So it just depends on the level of mutation. So basically the DNA is being altered from some unknown reason, like carcinogen, like cancer causing products like cigarettes, could be from environmental toxins. You know, there's a ton of different things that we think cause cancer, right? So it's going to cause this genetic mutation, or what type of mutation it causes. So is it going to cause it to just have the replication issue, but still everything else? Or is it basically going to change the whole cell entirely? Okay, because when you get a cancer cell, it's basically going to create a whole new like being, right? It's going to create a whole new cell, right? It's not going to do anything like the old cell. So is it mutated to just go crazy? Or mutated to just with the replication issue? Okay, does that make sense?
Okay. Yeah.
Yeah, so it's just the level and what it's actually being mutated. Okay. Any other questions, concerns about this? Okay. Why am I going over this? Because again, we are going to talk about the drugs that are going to be affecting these types of issues. Okay. Questions or concerns? I want to make sure no one is confused or has a question. Okay. Do you need me to leave this up for a second, or is everybody good with this?
Everyone's good.
Okay. All right. I'm gonna go back to the PowerPoint. Okay. So this is kind of what I was talking about, right? You can see the cancer cell right here. Right here is my normal cell, right? They have a certain shape, have a certain color, have a certain function. Then you have this thing, right? It completely got changed, doesn't look like it, doesn't function like it, doesn't do anything like the normal cell that it originated from, okay? So I don't know if this picture kind of gives you an example of how the cancer cell completely just morphs it, okay? Or the mutation just completely morphs that cancer cell. And it only takes one cell because then it starts to spread, right, from that one cell, okay? Just like a contagion, right? It takes one person, patient zero, right? And then spreads to everybody else. So just starts with one mutated cell and keeps going, okay? Otherwise, I have a picture here of the difference. I don't know if this kind of visually helps, but you have your benign tumor here, and then you have a malignant one here. What do we notice about the difference in the?
The benign has a border around it, the malignant don't, and then it's like the benign is like contained
Yep.
in one area.
Yeah, and then what do you notice about the shape and the size of the tumor cells on each?
They don't have a shape, and then the size of it is just irregular, like it's everywhere.
Yeah, like this doesn't look like anything, right? This just looks
Yeah.
like damaged, mutated crap, right? We don't want this,
Mhm.
right? This one place looks like this. It's still do the same function, so it's not going to impact the organ or whatever cells it comes from, okay? But yeah, you can see the edges, and here you can see the wildfire spread here, okay? Everything that I wrote here is just everything that I put on that little whiteboard app that I have, okay? So it is just rewritten there for you in a different way. So there is that, okay? There are a couple different types of cancers, okay? I'm not gonna like super harp on this, but the biggest one is, what is lymphoma? Because when you hear like the word lymphoma, what type of cancer is that?
Lymphatic.
Like, yeah, cancer of the immune system or cancer of the lymphatic tissue or the lymph nodes, things like that, right? Does that make sense?
Do them like do these is the ones that got to do with the T cells or the T cells or the B cells?
Yes, it would. Okay. And that can also be leukemia.
It
Okay.
would be the T cells, correct? With the
It can be
lymphomas.
it can be the lymphoma. I'm not sure exactly what white blood cell it targets. It could be the T cells. I don't know
Okay.
off the top of my head. Yeah, it could be. But basically, lymphoma and leukemia can target immunity, so they could both target like types of white blood cells. Okay. And then leukemia can also target the bone marrow. So what are the three things we make in the bone marrow?
Red blood cells, white blood cells, and platelets.
Yep. Okay. So do I want those levels to be altered? No.
No.
Right. Because then I'm going to get infection risk, bleeding risk, and anemia, right? Good there? Okay. So those are going to be the two biggest types of cancers that we usually see. They're pretty common. And then we also, you hear like the word carcinoma or sarcoma like tagged on to like weird front words, right? Like it's like a big name, but you always see carcinoma or sarcoma at the end, right? So that's kind of like the type of cancer. So carcinoma is just cancer of your epithelial tissue, which lines most of your organs. Okay. And then sarcomas are cancers of your tissue, which would be more like your bones, your cartilage, your muscles, things like that. Okay. Questions here? Just giving you some definitions. Okay. All right. Here's just a picture of your lymphatic system, which would be targeted with lymphoma. Okay, so like I said, yep, there are some white blood cells involved, and then the whole vessels and lymph nodes. Okay. Questions here? Okay. Just want to give you that visual. And then again, here's just the compare and contrast. You can look at that. Okay. All right. Any questions so far? We go with the intro material? Okay. So what is a anti-neoplastic drug? When you hear that word? Has anyone
If it
really
gives
heard that?
cancer,
Yeah. Yeah, that is going to be cancer drug. That is going to be your chemo. Okay. With that, okay, does it always have to be chemotherapy?
no, it could be radiation, right?
It can be radiation or it could be the like immuno or the targeted therapy. Okay. Because what are our four basic cancer treatments? We have cancer medications, so like we have chemotherapy or targeted or immunotherapy, right? We have radiation or we have surgery. Okay. Those are really our only means of curing it. Okay. Questions there? Okay. So chemotherapy, all right. What do we know about that? We said that it can't distinguish what is my cell and what's the cancer cell, right? So what does it end up destroying?
Um,
Yeah, all of it. Especially what of your cells does it like to destroy the most?
the,
Yeah, the blood cells or the bone marrow, right? Okay. It can destroy other things, but it likes to destroy those the most. Okay. Usually we use chemotherapy in combo. Okay. So what is it called when we use two drugs in combo? They work better together than separately.
Synergistic.
So most of these work in a synergistic effect. Okay. Some are safe to give together, some aren't. Okay. So you do have to watch that. Okay. You're probably not going to hear of a lot of these drugs. You would hear more of them if you worked on an oncology floor or an infusion center. Okay. Otherwise, what does it mean that these are vesicant? Anyone will know what that word vesicant means?
that they could be
That they can be what?
harmful.
Yes.
They can't be given in a vein or something like that.
Yes, they can't be given, they're harmful. They can't be given in peripheral IVs, okay? They need to be given through a central line, or in this case, through a port, which is what most cancer patients have, right? Because if you give it through a peripheral IV, it can literally burn your skin and like cause it to slough off, okay? So not good there. And then with these drugs, I'm not really going to list these too much. You can kind of consider these common side effects applicable to all of the drugs we're going to talk about. Okay. Is everybody good with that? So what would be like the most common ones? Those would be hair loss, right? Usually anybody that with a cancer drug, especially chemotherapy, loses their hair, right? We have an increased risk for infection because again, the bone marrow is suppressed. Okay. We have an increased risk for anemia and thrombocytopenia as well. Okay. And then we have nausea and vomiting. How many chemo patients get nauseous? Right? That's like a huge thing. Yeah. What's something that we can do for the chemo patient for this?
Give them Zofran before they go.
You could, yep. Okay. And then appetite changes. They may not want to eat. And then mouth sores. Okay. So these are going to be like your generic kind of applicable to all of these. Okay. So I don't know if I've mentioned them or not. You may see them mentioned. If not, you can just assume that they go for all of these medications. Sound good? Okay. Here's just your picture, right? This is kind of the mouth sores, the hair loss, GI changes, fatigue especially, okay? Weakness. Questions there? Okay. So what is targeted drug therapy? We kind of talked about this, but just someone give me the definition for that.
It targets specifically the cancer cells.
And not what? Yeah, you're
And not the healthy cells.
Yeah, the healthy cells, right? So it kind of just does the cancer cells. This would be a replacement or something that you could give instead of what?
Chemotherapy?
Yep. Okay. That's all I really wanted to go over here. Okay. And then anti-metabolites. Okay. This is going to be our first type of chemotherapy medication. Okay. So this is going to be our first class. So we are going to start here. Does anybody have any questions about anything so far before we start going into the drugs? Just want to make sure. Don't want anyone to be lost.
No.
Okay. Sounds good. Let me see. All right, so the first one is an anti-metabolite. This is the first anti-neoplastic that we are going to go over. So you're going to see here what the indications, the indications are why we take it, right? Some of these medications treat specific types of cancers, okay? So they found that these types of, like, let's say an anti-metabolite, right? They're better at treating some types of cancers rather than others, okay? Why would you see them also treat autoimmune diseases?
Is it due to the inflammatory response in the white blood cells?
Yeah, in a sense, because again, when we go back to the basic side effects, right? This one right here, is that going to help with autoimmune diseases? Right? And then last week, I think when we did the BRMs, what did they treat? We saw some of them that like actually treated like colon cancer, but also treated Crohn's, right? So we've already seen them treat dual functions. Does that make sense to remember that? Okay, so I don't want anybody to be like, whoa, why autoimmune disease on here? Okay. Does anybody have questions about that? I just want to make sure because that's just trying to like connect other chapters to the okay. So the types of cancers that this one treats, did I freeze?
No.
Okay, I just said my internet was unstable with this, so I just want to make sure. So it can treat a wide variety of tumors. So anti-metabolites are actually used pretty commonly for different types of cancer, but the ones that they work best with would be leukemia types of cancers. Okay. The mechanism of action here, this is kind of why we talked about how cancer happens and the differences between cancer and benign and normal cells. All right. It inhibits cellular growth. Is that a good thing? Right? If I have a
So it's
tumor,
stopping the cellular, so it's stopping the cellular growth.
yep. Because is that the whole problem here? That's at least one of the things that have been mutated, right? Is the control of that. Make sense? Okay. It does that by interfering with cellular reproduction. Okay. Cellular reproduction. Okay. So that would be the mitosis. Remember when we talked about that just briefly, the cell kill those cells or it's going to slow down how many times that one cell can reproduce. Because how many times should a cell reproduce normally? Only once, right? It should only produce another version of itself and then die. Okay, so this is going to try to regulate that back and try to get it back to a lower number of times that it will replicate itself. Okay, does this make sense? However, you see that this only affects tumors or cancer cells. So is that a good thing here? Right? It'll less likely hurt my cells, my healthy cells. However, just like all chemo medications, it still has the potential to, but this one probably wouldn't do it quite as much. Okay. Good
So
there?
this anti-metabolites, that's a targeted.
It would be more targeted, yes. Yeah.
Okay.
It's still a type of chemotherapy, but it would have more targeted effect than other types of medications.
Okay.
Miss Hyde, we think you're frozen.
I'll text her, y'all. Give me 1 second, okay? Oh, she'll be back in a minute. You guys, Miss Hyde says she trying to reboot now, okay? All right. Won't you guys go ahead and take a break, okay? All right, she says she's trying to reboot now.
About a 15.
Maybe 6 o'clock. Is that okay?
Okay.
Okay, and I'll stay on, just make sure she come back on. Yep, just turn your cameras off and your mute, okay? Thank
Okay.
you. All right. Miss Hyde,
Yes.
Hi, I told him to come back at 6, okay? I apologize. I didn't know how long it was gonna take for you to get
No,
rebooted.
no, I'm sorry. Yeah, my Wi-Fi just took a nosedive for some reason.
Okay, okay.
Okay,
So if
sorry.
you could just give him a few minutes, because a few students probably stepped out. Yeah.
Yeah, no, that's fine. We'll just yeah, we'll come back at 6. Perfect.
Okay, all right.
Thank you
Thank
so much. I'm
you.
so
No,
sorry.
no problem.
Thank you.
It happens. It's internet. Yeah, we can't
True.
control it. Yeah.
No.
Okay. All right.
Thank
Thank
you.
you. All right.
Okay. All right, are we ready to resume? Yes, no. All right, I apologize for the Wi-Fi issue. Restarted my computer. Hopefully it doesn't happen again. All right, did anybody have any questions about where we left off? Okay, let me go back to sharing my screen. I will go back to the PowerPoint and we will resume where we left off. Let me see. Okay, so we were on anti-metabolites. Okay. Again, we said that it stopped the
Is you gonna record it?
Yes, this is recorded. Yep. Yep, it is. Let me just double check. It is saying, yes, I believe it is recorded. Yep, we are good. Okay. So let me go back. So yes, again, this was a type of chemotherapy, but it acted more like a targeted therapy. Okay, just mostly trying to target the tumor cells or the cancer cells. So that is more helpful. All right, it kind of leaves some of my healthy ones alone. Okay. So like I said, most of these are used in combo, so that hasn't changed. Okay. It's contraindication and it's interaction. So these are combined because basically you shouldn't take it with this, and you have a higher risk if you take it with this. So that's contraindication and interaction. You should not take one of these drugs in this class with another drug of this same class. So for example, if we go to the names, if I'm taking methotrexate, which is a type of this anti-metabolite, if I take it with, let's say, pentostatin, and I take those together, I have a higher chance of all of these adverse effects happening because it's too much of the same thing. These ones are very, very, very toxic to my body. So if you take two of them together, you're enhancing the amount of toxicity. Okay. And that leads to dangerous levels, which you're going to see with a higher chance of the adverse effects that we're going to go over. Does anybody have any questions about that? Okay. So with the adverse effects, again, I'm going to have like the generic ones here. All right. But we said that those apply to every single type of these medications. So that's nothing new. All right. But then we also have this whole list right here is all the toxicities that an anti-metabolite can cause. So neurological toxicity, what would that look like?
Confusion,
Could be
um,
seizures,
features, yeah.
Lethargic.
lethargic, yep, drop in LOC, like coordination issues, unwanted involuntary movements, cognition changes, what else? Like encephalopathy issues. We go with that one. It's literally going to damage your brain. Okay. We also have cardiovascular and pulmonary toxicity. So that could cause like myocarditis, endocarditis, pericarditis, or it could cause like lung fibrosis issues. So anything that would cause inflammation to my heart and my lungs. All right. What would be the bad thing with that? Just generically, what would be the biggest thing if I had issues with my heart and lungs?
You could start having,
Breathing.
Everything would be affected, but basically at its base core, it would be low perfusion. Does that make sense? That would mean like less cardiac output overall. This would affect everything. Okay. All right, that is going to be my liver and that is going to be my gallbladder and my pancreas. Okay. And then we also have GI in here. So basically the whole thing here, we could get liver failure, we could get gallbladder, like cholecystitis, we could get pancreatitis. Okay. We could get inflammation of the GI tract, which can manifest itself in a lot of different ways. Okay. Genitourinary, that usually means my reproductive tract as well as my urinary tract. So there are your kidneys, your bladder, prostate potentially for men, uterus, all that kind of stuff. All right. It could affect your skin. And then it could affect your eyes and ears. So you could go blind, you could go deaf, or you could have hearing loss, things like that. And then what would be an example of metabolic toxicity?
Like weight loss, weight gain.
Could be, yep, yep. Or it could be thyroid issues, diabetic issues, things like that. Okay. So a lot of toxicities can happen here. It is very powerful form of a targeted therapy. Again, can also be used for autoimmune diseases, but it comes with a hefty risk. Okay. Questions here? All right. And then again, like I said, methotrexate is a form of this, but like we also learned last week, it is also a DMARD, okay? Because again, multiple drugs can go into different drug categories depending on their usage, okay? So methotrexate is a very, very common one here. No one has probably heard of any of the rest of them. Probably,
Hyde.
maybe, yes.
So you saying that anti-metabolites, when you say it can be used in combo to enhance the cytotoxic effect, so it's just increasing to kill the fast-growing cancer cells?
Yes.
Okay.
It works well with other cancer meds from other classes, not two of this class. So it enhances the cancer killing ability.
You're going.
You should not take two of these or more together. Any other
Miss
questions?
Hyde,
Yes.
Miss Hyde, you broke up again. Can you start your sentence back over, please? Yeah.
Yep. Sorry. Yeah. I just so yeah, the cancer, the anti-metabolites work well in combo with other drugs from other classes. However, you should not take two of these together.
Okay.
So anything on this list should not be taken together. Okay. Did that answer your question?
Yes, it
Or do you-
did.
Okay, perfect. Any other questions, concerns about the anti-metabolites before we move on to the next one?
Do you want us to know, like, the meds? Like, so for instance, if it was a test, if we were taking the test, would it ask the question of something along the lines of this med with this med? Like, do you want us to know all of these, like what the anti-metabolites would be, or?
I don't need you to know this whole list because that would just be cruel. But know the
I
first
agree.
know the first three: methotrexate, promexit. You know I'm horrible at pronouncing these. These three, and then no pentostatin. Okay, sound good?
Yeah.
Okay, perfect.
Thank you.
Any other questions? Yeah, of course.
Is pentostatin like a statin drug, like atorvastatin, or it's just like a coincidence?
That I actually was wondering off the top of my head too. Let me look that up really quick. Hold on. Is pentostatin a statin class medication? No, that is just a coincidence. Yeah. So sound the same, but completely different class. It is not a part of the statin class. But yeah, good question. I was wondering that too. Any other questions, concerns? Okay. Again, this is just kind of showing you just kind of a summary slide. I like these osmosis pictures. You know, you have the osmosis videos in your SurePath assignments. But again, it's most effective at treating leukemia, lymphoma. Okay, these would be the main two. But then, like we said, it can also be used for other types of cancer as well, just maybe not as effective as with these two. Okay. Questions, concerns? Okay. Our next medication is going to be a mitotic inhibitor. All right, that's our next type of anti-neoplastic. Again, used in combo with other types of anti-neoplastics because, again, they usually work better together than they do alone. They're stronger that way. These ones work really well with solid tumors, so kind of just like the anti-metabolites. However, they also work, again, really well with lymphoma and leukemia. So you can they basically treat the both similar types of cancer, okay? Its mechanism of action. When you hear mitotic inhibitor, what word stands out to you?
It's close to mitosis.
It
Mitotic.
does. Yep, exactly. The mitotic. Okay. This looks like, again, down here, mitosis. Okay. So if it is a mitotic inhibitor, how do you think it's going to work?
Inhibit mitosis.
Exactly, right?
Like the
And what is that going to do to my
genetic-
cancer cell? Yep, you are correct. What's that going to do to my cancer cell if I stop or slow down mitosis?
It's gonna stop the replication.
It is. And is that the whole issue here? Or one of the biggest issues with a cancer cell?
Yes.
Okay. So do we see how that works? So just knowing the name of the class can basically tell you the mechanism of action. Okay. Any questions with that one? I also want to tell you that it is made from plants that are found in nature. So things that are made from things in nature, or we take parts of, actual like plants and things like that. We always call those semi-synthetic. Have you guys heard that word before?
No, I have.
Okay. So an example again would be like we're taking like a plant from nature, we're putting it back into the lab and we're adding things to it, breaking it down, taking pieces from the plant and making it into a medication. So it's semi-synthetic.
You're breaking up.
You froze.
Yeah, she gone. Hey, honey, how are you?
I'm just coming probably to see about that Devion Jackson. Yeah, I don't let her go to Roseville.
No, Roseville? What's going, she want to go to Roseville?
Roseville, that means that last class.
Okay.
She missed class on Monday.
I thought it was Madison Heights. Okay, hold on one second. Give me a second. Let me text Miss Morgan, okay? Okay. All right, give 1 second, you guys. Yeah. I know it's raining bad down there. We got it last night, but they getting it tonight. So just give her a minute, okay? All right, she'll be back. All right.
Miss Neal,
If she doesn't wanna.
Okay, she don't want to drive. Okay, I'll check with Anna. Yes, sweetheart. Who calling me? Quenisha?
Breezy,
Breesley, yes,
How-
sweetheart.
how are we gonna get the full lecture? It didn't froze like 5 or 6 times.
So
and
I
I'm like,
understand that she's been recording it. Is that correct? No? That's
yeah,
what
but
everybody's been-
even
Huh?
during our recordings, it still
Okay.
records the frozen parts, and it's like we're not getting
Okay.
like all the important information.
Okay, so if she freezes, so first of all, I was on here last week and I'm on here this week. When she's freezing, nobody's saying anything. You got to speak up and ask her to repeat it. And, just let her, because she doesn't know she's freezing. So, yeah, you got to
When she's frozen, she can't hear us.
No. I'm saying when she come back, Lauren, you notice what I've been doing? I notice she freezing too. So when she come back, I'm like, Miss Hyde, you froze. Repeat that. You got to ask her to repeat herself. You're right. She can't hear you. So, and if you're listening to the recording and it's a part that you felt like was important, then you just have to email her and just let her know you were speaking about this part and you froze and you reiterated. Okay. Yeah.
Okay.
So, yeah, you got to tell her she froze. She don't know. Yeah. She just keep talking. Yeah. Mm-mm. Nice to see a nice full class today.
We always have a full nice class, Miss Neal.
Mm. Mm-mm.
Oh my goodness.
I know
I
I
don't,
wasn't feeling good last week, but you okay, Miss Hyde? It's okay. All right. All right. Go ahead. You guys go ahead.
I
We'll
lost
talk about
power yesterday, so I don't know if it
Okay,
has something
so
to do
Miss
with that.
Hyde, so when you freeze, I know you don't know you're freezing, so I've asked the class to let when you do come back on, like I've been doing, to let you know that you froze and to repeat anything that you said. Also,
Yes,
when you send the recordings, I'm understanding that when they're even going to the frozen parts are in there, and then they'll may have to reach out to you for clarification of things, okay?
yes,
Okay,
yes,
all right. Thank you so much. Okay.
yes.
All right, y'all.
Okay, so let me go back to where we were at. I apologize. I'm so sorry. When it comes to the mitotic inhibitors, I was just telling you that these are the names of the most common ones. And when you get to these ones that start with a V, if they are given by a spinal route, they would be considered fatal. What would be an example of a spinal route?
Or like like an epidural type situation, or like
Yep,
are you talking about like
yep,
route wise? Okay.
yep. That would be like an epidural or something that would be injected into the spine. Okay.
Miss
Um,
Hall,
yes.
I have a question. Referring back to the mitotic inhibitor, you said you wanted us to know about that it come from a plant. So you want us to know that it's the needles of the European yew tree? Is that something important to know or no?
It comes from the periwinkle plant and the mandrake plant. I just want you to know that it was taken from nature and manipulated into the lab, so it's considered semi-synthetic. Does that make sense?
Yeah. Okay.
Okay. All right. Any other questions, concerns?
Would that be the same concept of like progesterone that's given in the like the pure hormone form, I guess, so to speak?
Yeah, it depends on if it was given in the pure hormone form, where they got that hormone. If it came from like another human and they just like injected it into you, then that would be natural. But if they took it to the lab and they manipulated it, added things to it, then it would be semi-synthetic.
Okay.
Okay, because it's like half natural, half lab made. Okay. Anybody have
So
any questions so far?
is this
Yes.
one like the opposite of anti-metabolites? Like this one treat more of the solid tumors and some of the hemolytic um, malignancies, and then because the anti-metabolites treated more of the hematologic and then some of the solid tumor. So this like the opposite of that.
Kind of. They both treat tumors and they both treat leukemia and lymphoma. So they're similar in that regard. But yes, the anti-metabolites did tend to treat more of the hemo cancers than the solid tumors.
Okay.
Okay.
Um,
And plus, the anti-metabolites also treated the autoimmune.
Miss Hyde, I'm sorry, this is my last time interrupting. You know what I just thought about? Turn your
Yes.
camera off. Sometimes because everybody's on, if you turn your camera off and just lecture, I don't know if that's going to bother you or not, but as long as they
No.
can see the PowerPoint, I think that might help. So let's try that, okay? Is that okay?
Yeah.
Okay.
No. Yeah.
Okay.
I have
All
everything
right.
to help.
Okay. Yeah, you just turn your camera off. Sometimes it helps with the reception. I don't know
Okay.
why, but yeah, ATI does it all the time. So, yep, just turn your camera off. Okay, thank you.
Okay. Yeah. No problem. All right. Any other questions so far? We good?
Am I okay? I'm not sure if you might have just said it, but can you break it down a little bit in simpler terms of how this is different from the first one?
Yes. So let me see. When you have your anti-metabolite, okay, that was used to treat solid tumors in some hemolytic cancers. Okay. And when you go to your mitotic inhibitor, it also is used to treat solid tumors and some hemolytic malignancies. Okay. So they both treat the same types of cancer, except the anti metabolites tend to treat more of the hemolytic cancers than the mitotic inhibitors. Plus, they also treat autoimmune diseases. So if you had to go and just quickly write that out.
I think you just went out again.
Miss Nell,
I think that you were able to do the same thing.
I'm here, baby. Give me 1 second, okay? Give me 1 second. I'm calling Miss Morgan.
okay, thank you.
Okay, so I'm gonna finish the rest of the lecture and then send it to you. So I'm gonna start where we left off, and I'm gonna go and answer that question in terms of what the difference was between anti-metabolites and then the mitotic inhibitors. So I'm going to share my screen, and then I'm going to go to the whiteboard. Okay. With that, the anti-metabolites, all right, where we start, those treated my solid tumors. Those treated my hemo cancers, which would be my lymphoma and my leukemia. And those treated my autoimmune. The cancer that they treated the most, though, were my hemo cancers. Okay. And then I go to my mitotic inhibitors. Sorry if it'll let me click on this. Oh my goodness gracious. All right, my mitotic inhibitors, okay, those treated solid tumors. And then those also treated my hemo cancers. All right. They did not treat autoimmune diseases. Plus they kind of treated the solid tumors, and the chemokites treated the solid tumors, but they also treated the cancers more than the solid tumors, and they also treated the autoimmune. The anti-metabolites, you could kind of consider that more of a targeted therapy compared to the mitotic inhibitor. Okay, so hopefully that kind of spells out the major differences, and that answers that question. Otherwise, let's go back to the power. So we were on went to mitotic inhibitors. Again, I told you that they were semi-synthetic. That would be important. Okay. I told you that they worked during mitosis, okay, which was literally in the name. So it helped stop cell division, okay, of those cancer cells. So that was the whole problem, right? They keep dividing. So if we can limit the amount that it divides, that was one of the things that the mutation did. Hopefully, that'll help reduce the growth and the spread. Okay. I did tell you that these were the names. Okay. The names that I like the most would be these two, the Jabenta and the Halaven. And then this right here, all right, I need you to know that if it's given by a spinal route, these particular ones could be fatal, okay? So otherwise, I think that hopefully that clears up why we're giving them in terms of the differences from the other one and then this information right here. Okay, again, a spinal route would indicate more of like a epidural type thing where it would be injected directly into the spinal cord, spinal nerves, that type of thing. Because maybe like if you had cancer in that area, they may be able to inject it locally, things like that. There's different options, obviously, for how they administer chemotherapy. So just with this particular one, right, these ones right here could cause fatalities if you do give it spinal route. So that was kind of just something important to note there. Okay, again, they all start with your V. All right. My interactions, okay, I need to have caution if I use this with other anti-metabolitic drugs. All right, I know that you can use these in combo, okay? However, if you do use them in combo, you just have to be careful which other cancer drugs that you're using it in combo with, okay? because we don't want to make any kind of issues where we would slow down the efficiency of the drug. Okay. So just make sure that if you are giving this one with other types of chemotherapy medications, that you just make sure there's interactions as to is it going to affect one or the other's effectiveness. All right. I think that list was pretty long of the interactions, so I'm not going to have you know that. But just be aware that if you do take a mitotic inhibitor, use it in combo with any other type of class of chemotherapy drug, that it could affect the efficiency. So just make sure to look that up. Okay. When we go to mitotic inhibitors, again, they're very, very, very vesicant. We know that mitotic inhibitors, as well as all of the other types of chemotherapy drugs, are vesicant in nature, just generically, which is why they all have to be given via a metaport. However, mitotic inhibitors tend to be a little bit more heavily on the vesicantness, which means, again, that they can cause extravasation. Okay, I have a picture of extravasation right here, just in case you don't remember. But that's basically, again, where the vesicant solution, which would be the mitotic inhibitor here, would be given through a peripheral IV. And then it would literally start to burn or kill the skin cells around it, tissue, blood vessels, everything around it, and then like basically slough it off. You get a huge wound. Okay, so that would be the risk there. And as well as the other adverse effects, these pretty much look like my common chemotherapy side effects that I said you're going to see over and over again. So otherwise, there's nothing else that's really new here, except please, please, please make sure that this is given via a metaport. Okay. Otherwise, those were my mitotic inhibitors. Okay. Hopefully that helps. When we go to the next type, okay, these are called my alkaloid topoisomerase 2 inhibitors. Okay, whenever you hear or see the word ACE, all right, that usually notes that there is a enzyme involved. Okay, so we'll just keep that in mind with the mechanism of action when we get there in a second. Okay, I usually just abbreviate these alkaloid top inhibitors. Okay, I usually just call this whole thing top inhibitors. So the main drugs in this class would be my etoposide, and then my tenepopside. Okay, so please make sure that you are aware of these names. Okay, and then what this one is used for, because again, I told you some of these chemotherapy medications work better with different types of cancer. This is going to work better with lung cancer. Okay, and usually with testicular cancer. Does that mean that we can't use them with other types of cancer? Of course not. Some of these may work for other types of cancer as well, but we just seen that they work the best with lung and testicular. Okay. When it comes to my mechanism of action here, okay, I said again that when you see ACE in a name, it usually means that there is an enzyme involved. Okay. So here, it's going to inhibit the topoisomerase 2 enzyme, okay? I'm not going to get super crazy into that, but basically I just need you to know that this enzyme right here, by inhibiting it, okay, it is going to lead to the breakdown in DNA strands, okay? So why would I want to have breakdown in my DNA strands? Okay. Because again, what is the whole problem here with cancer? That is going to be, it all stems from mutations of my DNA, right? Whatever cell, got the cancer cell starting here, wherever point in my body that was, you had some mutation in my DNA. So if by inhibiting this enzyme, that is going to cause breakdown of the DNA in the cancer cells. Okay, so that would help maybe try to mitigate or reduce that mutation or the effect of that mutation. The bad thing is that, again, if you're breaking down the DNA in the cancer cells, you could also be breaking down the DNA in your healthy cells, killing them or damaging them as well. So again, just like chemotherapy, it doesn't necessarily know when to stop versus cancer cell versus healthy cell. Okay. But again, just to reiterate, by inhibiting this enzyme, we are breaking down DNA strands, hopefully in my tumor cells. But again, it's also going to happen in some of my healthy cells. Okay. Hoping to mitigate or reduce the effect of that. It's not used very much because it has a lot of toxicities. Okay. And by toxicities, I literally mean that this can cause basically toxicity of any organ, system, cell type that you have in your whole body. So when we saw some of the other chemo meds, those were causing like toxicity of the brain or toxicity of the kidneys, whatever that list was. This is probably going to double it, right? So you're going to have extreme toxicities here. That would be body wide. All right. It would probably cause a lot of cell damage or cell death. Because again, inhibiting this enzyme, it doesn't know necessarily sometimes which ones are tumor cells and which ones are healthy cells. And it can do this without really causing as much benefit. So when you do risk versus benefits, the risks here are usually higher than the benefit of it killing the chemo cell or cancer cells. So usually we tend not to give this one because the risk is too high. Does that mean that they don't use it at all? Of course not. They still use it. But it's definitely not the go-to drug. Okay. This would be like, we would try other things first. If those don't work, then we would obviously try maybe this one. Again, has to be given IV. By IV, all of these have to be given via alkaloid topoisomerase 2 inhibitors. All right. And I think we are good with that one. This next one would be, it sounds very similar to the last one we just did. All right, but this is topoisomerase 1 inhibitors, where the last one was alkaloid topoisomerase 2 inhibitors. Okay, so sound very similar, okay, but two completely different types of anti-neoplastics. So please don't get that confused. Okay, this one also has the ACE in it, so it does deal with my enzyme as well. Okay. This one is also a semi-synthetic, okay, because it is made from a shrub, okay. So what that means, again, is that they took the shrub or took elements from the shrub, took it to a lab, manipulated it to make it into a medication. This one would be another semi-synthetic drug, okay. The names for this one, otapotectin and irinotecan. Okay, so they both end in tectin. Okay, but please make sure that we are familiar with these names. Okay, there's only two, so please make sure that you are aware of those. Okay. Again, it's used, the ones that this one works the best to treat would be ovarian cancer and colorectal cancer. Okay. Colorectal cancer can be basically any cancer of the large intestine and the rectum anus area. Okay. So those would be the cancers there. Usually you probably see like polyps in the colon, and then you would start to see those tumors spread, which is why you need your colonoscopies after you hit middle age. So again, these are the two types of cancer it works the best with. And then we get to the mechanism of action. Okay. It's going to inhibit improper DNA function. Okay. I don't have it written out there like I did before, but basically the mechanism of action here is going to be the same thing. We are going to inhibit the topoisomerase inhibitor, which is going to damage that DNA function of that cancer cell, which is going to hopefully stop the mutation or stop the growth. All right. So again, alkaloid topoisomerase 2 inhibitors and topoisomerase 1 inhibitors work very similarly. Okay. If you had to put this on a whiteboard here, all right, to do a comparison, okay, just to kind of make it so it stands out a little bit more to you. Okay, my alkaloid, if I could spell it right, alkaloid top 2 inhibitors. All right, these ones mainly treated which type of cancers? If we go back and look, those were my lung and my testicular. Okay, so this mostly treated lung and testicular cancer. Okay, obviously the names are different for both, so I'm not going to write that out. You just have to know those. All right, the top 2 inhibitors, the mechanism of action for this was that it inhibited or stopped the topoisomerase 2 enzyme. All right, and by doing that, we damaged the function of the DNA, okay, of particular cells. Again, the cells that we're hoping that we damage the DNA in would be my cancer cells. All right, by damaging the DNA, again, that would be, sorry, okay, this came back, sorry, it froze. I just deleted what I just wrote. Okay, let me rewrite that for you. Give me 1 second. Great. Sorry about that. This kind of had a little fluke here. Okay. So the top 2 inhibitors, all right, are my alkaloid topoisomerase 2 inhibitors. Again, those work by of cells. Okay. The cells that we're hoping that it affects are obviously going to be the cancer cells. Okay. So by inhibiting the cancer cells, okay, we are going to hopefully lead to less, I don't know what it is, less cancer cell mutations. All right, and that mutation again is mostly the one that we really want to target is going to be the replication. Okay. Right, so hopefully by damaging the DNA in these cancer cells, we're going to damage the mutation, right? Because the mutation was in the DNA. All right, so hopefully we'll break down the amount that it keeps replicating and replicating and replicating. All right, and then hopefully we will reduce cancer cell growth. Okay, so hopefully we will take that tumor and make it so it's not growing quite as fast or quite as extreme. Okay, that would be your alkaloid topoisomerase 2 inhibitor. Okay, and then if we go back to the alkaloid topoisomerase 2 inhibitors, we would just finish that. And then again, I just want to add to this one right here that if you go back to here, all right, that this one right here, the alkaloid topoisomerase 2 inhibitors, are not well tolerated. Okay, so that doesn't mean that they're not used. All right, that just means that they are not the drug of choice. Okay, so that means that if I have to give you a chemo drug, I'm not going to be, oh, let's give you the alkaloid topoisomerase 2 inhibitors. I'm going to try to give you obviously a different one that may be a little safer. All right. But we may have to resort to this one if those ones aren't working. Or again, maybe this one's the best one for the job, but it's not my go-to. All right. And why is that the case? Because it causes a lot of toxicities. So if you thought that other one that we went over in the beginning with that huge list of toxicities was bad, this one would cause toxicity of any type of tissue cell that you have in your whole entire body. Okay. Sorry about that. Going back to the topoisomerase 1 inhibitors, right? Because we just did the alkaloid topoisomerase 2 inhibitors, summarize that. So again, I'm doing a compare and contrast chart to try to highlight the differences. All right, this one right here is more used for treating, we said, ovarian cancer and colorectal cancer, okay? Whereas the other one, again, was my lung and testicular, okay? Again, I'm just comparing and contrasting these because they're very similar. The names are almost identical. So I just kind of want to make sure that there's no confusion. The MOA here is basically copy paste, except it's going to stop the topoisomerase 1 enzyme, okay? Whereas the other one was stopping the topoisomerase 2, all right? So the alkaloid topoisomerase 2 inhibitor is stopping the topoisomerase 2 enzyme, whereas the topoisomerase 1 inhibitor class is stopping the topoisomerase 1 enzyme. And I know that it's a mouthful, and I know this is probably confusing. So hopefully this compare and contrast chart helps, okay? So again, this one's stopping the topoisomerase 2 is stopping the second inhibitor of this, and this one is stopping the first. However, they both do the same thing. So when I stop the enzyme, the first one or the second one, it doesn't matter. It's still going to lead to damage in DNA functioning. Okay. And again, we're hoping that that functioning goes to cancer cells. It can also go to healthy cells as any other type of chemotherapy can. But again, we're hoping that it mostly affects my cancer cells because when we damage the DNA of something, again, we're hoping that that will damage the DNA part that was the mutation that was responsible for replication. Okay. Which again, we're hoping ultimately will reduce the cancer cells growth, just like we saw on the other one, okay? This one is better tolerated, okay? In terms of the differences between the two, the top 2 inhibitors not as well tolerated where the top 1 inhibitors are, okay? And then if you go back to the PowerPoint, okay, we do see, all right, again, just wanting to show you again this compare and contrast chart, okay? In case it didn't show up correctly, just want to check. All right, comparing and contrasting the two, okay? And then if we go back to the PowerPoint again, okay, we can see that the names obviously are different. And then if we keep going into the topoisomerase 1 and finish those up, those do have interactions that we need to consider. All right, so those would be my filgrastim. If you don't remember, filgrastim was one of those BRM medications from the hematopoietic category of those, and that helped stimulate the bone marrow to produce more white blood cells. So if you this with the TAPIO1 inhibitors, all right, what's going to happen is that you're going to make your bone marrow suppression worse, okay? Because basically we're taking the filgrastim to stimulate the bone marrow, and then this medication, again, like kind of like all of our chemotherapy medications, is going to damage the bone marrow, suppress the bone marrow. So it's basically counterintuitive. It's not going to allow the filgrastim to work. So it's not going to end up increasing the white blood cell count. It's just kind of going to, they're going to cancel each other out, if that makes sense. So there's no point in taking it. Okay. Also, if you take the topoisomerase 1 inhibitors with laxatives or diuretics, okay, it can cause severe dehydration. Okay. And with a cancer patient, they're already not drinking, they're already nauseous, they already have appetite issues. So any type of fluid loss is not ideal here. And then when we have this medication with anti-metabolites, okay, so that was the very first class that we talked about, okay, in this PowerPoint, you have a higher risk of cardiovascular toxicity, okay? Because remember that anti-metabolites had that huge list of all the toxicities that it caused. Okay, so if you take it with an anti-metabolite, you're going to emphasize the cardiovascular toxicity, okay? So examples of cardiovascular toxicity would affect my circulation, so maybe clotting issues, hypertension, PEs, okay, as well as like reduced cardiac output, high risk of heart attacks, inflammation of my heart tissue, all that kind of stuff, okay? Basically, that's pretty much all for the interactions. So if we go back to my chart here, okay, and we add to it, all right, and we put for the interactions that if you take this with filgrastim. All right, they're going to cancel each other out. Okay, so it's going to not produce the increase in white blood cells that you were hoping for by taking the filgrastim. Again, you should not take this with laxatives or diuretics, okay? Because laxatives and diuretics, their whole purpose is to have you lose stool or to have you lose urine. And that stool and that urine is fluid, obviously. So again, you have a higher risk of dehydration, okay? Which again, with a cancer patient can be pretty serious. And then again, lastly, if I mix this one with we just go back and look, with my anti-metabolites, okay? Just refreshing that. So my anti-metabolites, which again is a type of anti-neoplastic. It was the first one that we went over, okay? Remember, this type of anti-neoplastic had a ton of toxicities, okay? We had that huge list that, yes, you need to know, all right? It would lead to cardiac toxicity, okay? And again, with the cardiac toxicity, you were at an increased risk for PEs, MIs, cardiomyopathy, dangerous types of like heart failure, inflammation of the heart tissue, low cardiac output, a ton of different issues that it can affect a lot of different things, okay? So hopefully, again, this compare and contrast chart helps, compare the difference between the two. But if we go back to the PowerPoint, okay. The adverse effects here are going to be bone marrow stem therapy medications anyway. Same with the nausea, vomiting, and diarrhea, okay? But you can see why here that may be more emphasized, because if it causes nausea, vomiting, diarrhea, right, that may make the dehydration risk with this one higher, okay? And then it can also lead to headache, rash, muscle weakness, and cough. Am I super concerned about these? No, because to here, they are more mild than the ones over here. So definitely that is a plus. So my adverse effects with this one would end up being, again, headache, rash, cough, okay, weakness. And again, the weakness is a little concerning because the chemotherapy, kind of kills your healthy cells, makes you more at risk for weakness in general, okay? So again, these would be, and then your topoisomerase 1 inhibitors. Again, I know they're very similar, so hopefully this compare and contrast chart kind of breaks down the differences and kind of summarizes it, makes it easier to condense the information. So those would be those two, okay? I will leave this up here for just another second if you were looking at it, but I know you're going to be replaying this, so you can just pause it and write this down if you need to. All right. So I'm going to go back to the PowerPoint. When we go to the next type here, this is the last type of anti-neoplastic for this chapter. This is going to be your anti-neoplastic enzymes, okay? So this would be another type or class of anti-neoplastic. The most common drug names that you will see will be, I'm not going to pretend to pronounce these, all right? But they both end in ACE, okay? And hopefully that's easier to remember, because again, anything that ends in ACE usually has to deal with an enzyme, all right, which is literally in the name, okay? But if I go by the names, you should probably know these names as well as their brand or trade names, okay? And then I do want you to know that this one right here, the Erwinia version of this one needs to be specially requested from from the Cancer Institute, which means it's very dangerous, more severe, more harsh on the body. So this one isn't typically used very often. It needs a lot of precautions, so it needs special permission, special requesting to even pull this and to administer it. So again, the ones that you typically would see would be the Elspar and the Oncaspar. I can say those ones, so that's what I'm calling these. All right. But again, please remember that the ACE in these endings has to do with the enzyme part of the word. Okay. The indication for this one works really well with lymphoma or leukemia. Okay. With lymphoma or leukemia. Okay. So again, cancer of the blood products, which would be my red blood cells, white blood cells, and platelets, as well as cancer of my immune system as a whole or my lymphatic system. Okay. The way this works, okay, is they actually made this with cultures of bacteria, and those bacteria's DNA. Okay. So basically, they took bacteria. They took the DNA in that bacteria, and then they literally lab created an enzyme to destroy that bacteria. The enzyme is also able to kill or interfere with cancer growth. All right. So literally, again, just to summarize the mechanism of action here, the anti-neoplastic enzymes, we're literally dealing with a human lab-created enzyme that does not naturally occur in the body. Okay. So the lab actually just, made this out of their own, manipulation of things. And what they manipulated was a bacteria, okay, to make this enzyme. And what this enzyme does is it helps interfere with cancer cell growth, which again is the whole problem with the reproduction, overgrowth and things like that. Okay. So just to summarize one more time, just to try to explain it in a different way. Humans took a bacteria. No, you don't need to know the name of it. Took a bacteria, manipulated it in the lab, Petri dishes, did a bunch of kind of crap to it. Okay. Then they ended up with an enzyme. Okay. So they took parts of the bacteria, all right, and turned it into a completely new enzyme that doesn't occur naturally in nature. Okay. And then they made a medication out of that enzyme that will help destroy cancer cell growth. Okay. So again, just trying to explain it in different ways since you're not here for me to answer questions. So hopefully that makes sense. Okay. So we used the bacteria to make a higher risk of hyperglycemia. Okay. Because when you take prednisone in general, you have a higher risk of hyperglycemia. So this kind of exacerbates that. And if you look at the adverse effects, okay, you have a higher risk for hyperglycemia in general. Okay. Because the whole adverse effect here is going to be impaired pancreatic function. So that literally means that it could make it so that your pancreas doesn't function the way that it should. Okay. And with that, obviously, you're going to see issues with hyperglycemia and pancreatitis. Okay. So when we talk about prednisone, okay, that prednisone raises your blood sugar levels. And then this also has an adverse effect of raising your blood sugar levels. So both of those together definitely gives you an even higher risk of hyperglycemia. Okay. The next thing is that if you mix with methotrexate, okay, remember that methotrexate was a DMARD, and then it also was an anti-metabolite type of anti-neoplastic. It can reduce the effects of the cancer treatment as a whole, right? Because if you're taking it with methotrexate, if you're taking anti-neoplastic enzyme with a methotrexate, you're probably taking it as a combo, okay, to treat the cancer. You're basically going to decrease the effectiveness of the cancer treatment as a whole. So probably, again, not the best to mix these two together, all right? If I take this with an NSAID or with a blood thinner, okay, it is going to mess with my coagulation, okay? So as we know, NSAIDs like Motrin, Aleve, aspirin, they are considered a minor blood thinner, or, anticoags are actually blood thinners. You're going to you can have fluctuations of your blood clotting. So either it might make it clot too much, or it might make it clot not enough, or like enhance the blood thinner effect. So you can get either or there. So these are some pretty serious interactions. And again, the most common adverse effect is going to be pancreatic function issues, which again leads to hyperglycemia and pancreatitis. Okay. And that pancreatitis has the potential to be fatal. Okay. Which again is very, very serious, because your cancer patient is sick to begin with. But if you want to add fatal pancreatitis to that, it's going to make it a lot worse. Okay. Otherwise, I think this is pretty much the gist of my anti-neoplastic enzymes. So let's go and look at the nursing implications really quick here. Basically, if you're going to give any kind of medication, we need baseline blood work. All right, so that's going to be your white blood cells, red blood cells, platelets, all of my like liver enzymes, my kidney, markers, my B1 creatinine type things, my electrolytes, because I need a baseline, right? Because my chemotherapy is going to make those labs go all over the place, right? So I kind of want to know what I'm starting with, so I know if they're affected. Okay. Also, I need to know if that I'm giving. Some may have aware of that. Adverse effects need to be monitored very closely, because again, a lot of these cause really serious toxicities, or like reduction in immune system. So not very safe. So please make sure that you're watching your patients if you are giving these. Okay. Again, with the nausea, we kind of said this, but you need an antiemetic to work 30 to 60 minutes before chemotherapy would be the best to help mitigate that nausea and vomiting. Okay. Which is a huge adverse effect with all of these. Okay. We also need to give infection prevention precautions, like wearing a mask, staying away from people that are sick, staying away from large crowds. You probably don't need neutropenic precautions unless their white blood cell count drops pretty low. All right. And then you're going to need a non-drug form of contraception, because usually your birth control pills and like the medication type of birth control may be impacted. Okay. They may not work as effectively. All right. So this was your chapter 25. All right. My first round of anti-neoplastic drugs. And then the rest will be in chapter 46. So again, that is basically my part 2. Okay. So I'm going to go back to the internet here. Okay. So that was 45. And throughout any of this, if you're watching this and you have any questions, please email me. And then we have our tutoring session on Thursday. Okay. So if you're watching this and anything doesn't make sense, write it down. Hopefully, we can go over that Thursday, or you can email me. All right. But in a second, we will go ahead and start 46. Okay. Which again is just anti-neoplastics part 2. All right. All right, so we are going to start with chapter 46 now. So I'm going to share my screen and go to that PowerPoint. Okay. So just want to make sure it's working. Give me 1 second. Screen, I'm recording. Okay. So for this one, for my anti-neoplastics part 2, all right, the first anti-neoplastic that we're going to do is going to be my alkylating drugs. Okay. So alkylating drugs are our next type of cancer medication. I do have to tell you that this one came from mustard gases. So what I mean by nitrogen mustards is that this again came from mustard gas. Okay. Mustard gas is a type of gas that they used in World War I and World War II. Those gases would basically severely enable the, soldiers on the other side, and they were kind of deadly. So what they did is that they realized, hey, this kills people. So they took it and they manipulated it in the lab, and then they saw that it would kill cancer cells. If it kills people, it can kill cancer cells. So this was one of the first types of cancer drugs that you would see. So basically, if we go back, the first one that was ever made was mechlorethamine. Okay. So this was a first generation. And by generation, I mean each generation that comes after it was an approved upon version of the first one. Okay. So every generation it gets better. So I have a huge list of all of the types of drugs that they have improved upon in this class. Okay. But again, they all stem from the manipulation of mustard gas into making it a medication. Okay. So the ones I want you to know are procarbazine. All right. Again, methylorethamine. Let me see which other ones. These two and dabicarzine. I will just have you know these ones. Okay, the ones highlighted. Okay. And then we should one. Okay. That they made probably back in the 40s, 50s. And that obviously it has been improved upon. Okay. What kinds of cancers does this one treat? A wide range. Okay. Wide range. So that basically means it can probably work for a vast majority of cancers. So just know that it helps with a wide range. Okay. So you don't have to know any specific ones. Okay. So this one is very, very effective. Otherwise, the mechanism of action is that it prevents cancer cells from reproducing, and it helps kill the cancer cells. Okay, helps kill them, helps stop them from reproducing. Okay, because again, if mustard gas can kill a soldier, they can manipulate that mustard gas into a chemotherapy drug to kill cancer cells. All right. However, we're going to skip this for a second. If it can kill cancer cells and it can kill soldiers, it can kill you. So there is a ton of different toxicities right here, okay, that are very, very deadly or that can turn deadly. So we have the GI system, bone marrow suppression, and severe nausea, vomiting. We know that goes with all of them. Okay, we have nephrotoxicity, which is going to be my toxic to my lungs. Okay. Pulmonary fibrosis can cause increase in respiratory infections. It can cause a decrease in your pulmonary functioning. So if my lungs don't work very well, it could lead to decreased gas exchange, which would lead to decreased perfusion. It could lead to lung cancer itself, even though, again, this is treating cancer. And it could lead to issues like pulmonary hypertension, blood clots, all that kind of stuff. Okay. Emphysema, COPD. So not a good place to start. Okay. Again, if it can kill soldiers, it can kill you. And this would be some of the ways that it would do that. There is prophylactic measures. Okay. One of those prophylactic measures would be taking like a steroid before you take this. Okay, so a steroid that they tend to use pretty often would be dexamethasone, I believe, which would be Decatron. So if you see that one, again, you could probably take that beforehand to mitigate some of the side effects, as well as there may be other medications that you could take as well. Okay. And then my interactions, okay, I should avoid taking the alkylating drugs, okay, with any other medication that is capable of causing similar toxicities. So if I have a medication that can cause nephrotoxicity, like for example, that could simply be an antibiotic. Okay, a lot of antibiotics cause nephrotoxicity. And I took that with at the same time as one of these alkylating drugs that would enhance the nephrotoxicity because they both can cause that type of toxicity. All right, so I'm not asking you to memorize different types of drugs that cause these toxicities. I'm just asking you to know that if you take one of these alkylating drugs with any other type of medication that can cause any of these toxicities, you're going to amplify the effect of those toxicities. So it would be beneficial to your patient that those not be mixed. Okay, so just something to watch for when you're giving these cancer meds with other types of medications. Okay. Otherwise, this is just a picture showing you what can happen when you have lung toxicity. My alveoli, where I get the gas exchange and air into my lungs, can get inflamed, damaged, which again can lead to things like COPD. Okay. So that would be it for my alkylating drugs. Okay. The next type of anti-neoplastic going to be my cytotoxic antibiotics. Okay. My cytotoxic antibiotics. Yes, you did hear that right. They are involving antibiotics into this, and I will tell you how in a second. Okay. But for this next type, my cytotoxic antibiotics, okay, they all end in sin. Okay. So maybe that I want you to know are this one, daunorubicin. Okay. I want you to know doxorubicin. Okay. And I want you to know bleomycin. Okay. And you're going to see why I want you to know those particular ones in a second. All right. So please know those three names. Okay. The type of cancers that it treats is a variety. Okay. So just like my one before it, these can treat a wide range of cancers. So it has been proven effective with a lot of different types. So this would probably be more of a go-to type of chemotherapy drug. All right. The one thing that I want to emphasize here is while it does treat a bunch of types of cancers, a specific type of cancer that it treats, which is important here, is AIDS-related cancer. Okay, cancer would be Kaposi sarcoma. So if you look here, that is the type of cancer that again affects AIDS patients. It doesn't necessarily have to just be AIDS patients, but it's usually caused from, I believe, a type of herpes virus, because there's a bunch of different types of herpes viruses. And of course, AIDS patients don't have an immune system, so they're more likely to contract this. So you would see, a lot of these lesions on their body. Sometimes AIDS patients don't even know they have AIDS until they get a type of cancer like Kaposi sarcoma, which is like brings them to the hospital and they, start to investigate why and they see that. So I do just want to emphasize that it does treat this particular type of cancer, whereas other types of chemotherapies do not. Okay. Also, the mechanism of mycin types of, okay? So streptomycin antibiotics are made from this type of mold, okay? And then it's going to be manipulated in the lab, okay? So just to simplify this, cytotoxic antibiotics are made from a manipulation of streptomycin antibiotics, okay? They're made from a lab manipulated version of the antibiotic streptomycin, okay? Which again is why you see all of these ending in "sin," okay? We don't need more specific than that. Okay, treat cancer. What it does is, and by interacting with the DNA, it's actually going to stop the DNA from even being made. So if we go back to mitosis, where the cell is replicating, the cell, the original cell. Let me go back to the whiteboard. Hold on one second. The original cell, all right, that started the whole mitosis process, all right, is going to be here, okay? Let's say this is the one that's mutated, so just M for mutated, okay? This is the one that keeps replicating over and over and over again, all right? When it replicates to produce another version of itself, it has to make all the parts that are inside of it so that it can have parts to send to this one, right? You can't just make an empty cell. It has to have parts inside of it. And what starts off that process of making more parts is going to be the DNA. All right. The DNA is going to tell like that. Okay. So, sorry, this malfunctioned again. So that we can go ahead and have another copy of us, right? So this is my muted cell, all right? It has this version of itself, right? So by doing that, again, the DNA is going to be the one to say, hey, make everything double ahead and interfere with that DNA, all right, it may stop that mutant cell from making another version of itself. Because if it doesn't have instructions on how to copy itself over, or the instructions are destroyed, it's going to affect the reproduction process. All right, so hopefully the replication and the continuous mass replication of itself to spread would be reduced. Okay. So hopefully kind of seeing me draw this helps. If not, again, send me an email. But what they're doing is, again, they are manipulating in the lab. And by causing streptomycin, and by manipulating streptomycin, okay, it is going to therefore, interfere with that DNA. Okay, the medication will there be far more powerful, and then it will be able to interfere with the DNA of the cancer cell that keeps replicating. It's going to say, hey, DNA, stop telling that cancer cell how to make more of itself. Okay, so that is going to be my mechanism of action here. Okay. And then my interactions for my cytotoxic antibiotics. All right. It has a lot of different interactions. The chart in the book was beyond excessive. So just to simplify it, to keep it simple, all right, is that this medication, if it's mixed with other types of chemotherapy medications, which again, these are sometimes used in combo, so we have to watch this. All right, it can cause toxicities. Okay. So just know that it has a risk of causing a lot of different types of toxicities. Okay. And then if you take bleomycin, especially it causes toxicities if you take these cytotoxic antibiotics together. All right. So again, it can cause toxicities if you take it with other types of medications, but it can also cause toxicities if you take different ones in this class together. So like, again, we saw this huge list, right? So if you were to take any of these together, it would cause dangerous toxicities. I'm going to give you an example of a few that I need you to know. Okay, if I take bleomycin and doxorubicin together, okay, with digoxin, all right, you are going to get digoxin toxicity, okay? And digoxin toxicity, the most dangerous thing that can happen from that is a dysrhythmia, okay? And then when we go to the adverse effects, okay, the dianarubicin and the doxorubicin, okay, those both, when taken together and on their own, they can just cause, in general, adverse effects of the heart. So it can cause cardiac toxicity, okay? So that could lead to left ventricle failure. If your left ventricle fails, you're basically going to go into VFib, asystole. So you're going to be flatlined. You're not going to be alive any longer. All right. On its own, not when it's mixed with anything, because we know when it's mixed with doxorubicin and digoxin, it can cause digoxin toxicity, but just bleomycin on its own, all right, that is going to cause pulmonary toxicity, okay? And when I kind of told you before, pulmonary toxicity can lead to lung failure, COPD, chronic, lung diseases, issues with gas exchange, your lung could collapse, all that kind of stuff, okay? Whoops, sorry. All right, so again, I just wanted to reiterate that if you take cytotoxic antibiotics with other types of medications, just in general, other types of cancer medications, especially, you have a risk of toxicities. And then I have the examples of the toxicities down here, okay? That's just a review of digoxin toxicity if you want to look at that. But again, like I said, the dysrhythmias would be the most threatening thing that would do, okay? I'm going to go into some miscellaneous types of cancer medications. They don't really belong to a specific class. So I'm just going to give you the, again, these aren't classes, they're just specific medications. Okay. All right. So the first miscellaneous one is going to be Avastin, or however you want to say this. But again, remember it ends in MAB. So that's telling you that it is more targeted. Okay. Kind of like the BRMs that we learned about, okay, last week. You don't need to know this. What it treats is more colon cancer, rectal cancer, lung cancer. So as long as you remember like colorectal and lung cancer, you should be fine. But those would be the two that they work best on. Okay. The way that it works is it stops new blood vessel growth. Okay. So what happened? I have this big tumor now. Okay. This tumor needs blood and oxygen, just like all of the other cells in my body. The blood vessels that were originally there were not designed to feed all of these massive new cells. So they need a new blood source. So they expect the body to produce more blood vessels to feed it. So kind of forming extensions on the blood vessels that are already there to reach the new, massive cells. What this Avastin medication does is it helps stop any new blood vessels from growing. So basically what we're doing is we're starving the cancer cells that have just grown. They're there, but they're not getting any blood or oxygen supply because we're stopping the body from even being able to make new blood vessels to feed it. Okay. So basically, if we go back to this thing that keeps malfunctioning on me, Just very quickly here, if I have a blood vessel here, okay, it's supposed to supply blood and oxygen to this clump of cells that were always here, okay? And then now let's say this one becomes mutated, and this is now a cancer cell. All right, it's going to make a tumor, right? It's going to make all of these new cancer cells as it replicates and replicates. But this blood vessel right here isn't big enough to feed all of these, right? It was only meant to feed these original grouping of cells. So what, again, the cancer expects the blood vessel to do is to grow. Let's make it bigger. Let's make it longer. New cells. So what the Avastin does, if it's going to go in and it's going to be like, nope, we're not doing that. It's going to make it so that none of this can even happen, right? You're not even going to be able to get any of these new blood vessel growth. So then what ends up happening is that these new tumor cells are there, but they're not going to have any blood or oxygen feeding them. So we're basically starving them to death with blood and oxygen. So hopefully that kind of helps show you a little bit as to what I'm talking about with that. Again, if you have any questions, please let me know. But with this miscellaneous one, we're basically kind of killing it by not giving it blood and oxygen, okay? So if I go back to the PowerPoint, all right, let me see. Okay. My contraindications with this, the only reason that I really shouldn't be taking it is if I'm allergic to murine products. All right, murine products are usually eye drops, okay? Sometimes they're really just called murine on the bottle, or sometimes they are an ingredient. So if you are allergic to that, similar types of ingredients are used in Avastin, so the allergic reaction would be to this one as well, okay? This one has a huge list of adverse effects, so let me point out the big ones to you. We have hypertension and hypertension. So basically you can get fluctuations in your blood pressure, okay? You can get DVT, so clot risk. You can get dizziness, all right? You can, get dizziness. All right. You can get weakness and fatigue, but again, that goes in dry skin, that kind of on anorexia or weight loss, that kind of goes with all cancer. Okay. Hypokalemia is new. So again, low potassium. Nausea, vomiting is a common side effect. So we're not going to include that. Same with diarrhea. All right. But nosebleeds are okay. So we're going to focus on GI hemorrhage, all right, which would probably manifest itself as blood in the stool or blood in the vomit, okay. Nephrotoxicity, so it could damage my kidneys, all right. And then an increased risk of upper respiratory tract infections, so more risk of colds, sinus infections, all that kind of stuff that would make a patient that already has a low immune system from the medication more at risk, okay? This one is only given in IV form, which again, most of these are again, so hopefully this is really all you need to know for the Avastin, okay? All right, so the next one is gonna be hydroxyurea. You've probably heard of this one, okay? Hydroxyurea. Okay, this one treats more than just cancer, okay? They give it for a couple different things. The best cancer that it works with is going to be leukemia. All right. And then it also helps work again in like a combo with head or neck cancers like laryngeal cancer, esophageal cancer, like facial cancer, something like that, when it's used with radiation. Okay. So that combo tends to work really well. All right. It also can be used with sickle cell anemia. Yes, you need to know that. Okay. The way that this works, okay, it interferes. All you need to know is that it interferes again with DNA creation. Okay. So it's going to make it so that these new cancer cells that keep replicating and keep being created we're going to interrupt the DNA that's telling the cell to make those. Okay, kind of interrupting or messing with that mutation that got screwed up in the first place. Okay. And don't worry about any of this, just know this part. Okay. My interactions. All right. Let me see. The only one I really want you to know is that if you take it with other anti-metabolites, okay, so that very, very first class that we talked about, it can cause neurotoxicity, okay? Because again, the anti-metabolites had that huge list of all the toxicities that it could cause. So this one increases the risk for neurotoxicity, okay? My adverse effects here, let's try to pick out the big ones. It can cause edema. Again, edema on its own isn't super serious, but when the edema builds up and you start to get fluid around your heart, fluid in your brain, fluid around in your lungs, that's when I start to get concerned. So that could end up being severe. The other ones, again, if they're common side effects of chemotherapy, I'm not going to include them, okay? But hyperuricemia, okay, that is gout, because it's basically high uric acid in the blood, which is gout. Okay, so again, it could cause gout. Dysuria, it could cause difficulty or painful urination. Okay. Elevated liver enzymes means that it's going to potentially damage my liver. Okay. Peripheral neuropathy means that it could cause damage to the nerves in my extremities, causing the numbness and tingling in my legs and feet. Okay. It can cause damage to my kidney. All right. So damage to my liver and damage to my kidney. Okay. And then it can cause dyspnea or pulmonary issues. So difficulty breathing or lung toxicity. Okay. Those would be probably the key ones I would want you to know. The rest are pretty much just like the common ones that are kind of for all of them. Okay. The weird thing about this is that it's only given orally. Okay, the rest of these were given by injection, right? By IV infusion through the Metaport. This one is given orally. Okay, so please make sure that you are aware of that. All right. Okay, and please know that it can also treat sickle cell anemia. That is a huge, also big thing that can treat. Okay. All right. Otherwise, that's it for hydroxyurea. This is just some, again, examples of what neurotoxicity may look like, okay? Seizures, fatigue, headaches, mood changes, cognitive dysfunctions, sensory issues, all right? The next one that we're going to do is Gleevec, all right? I will refer to it by this name. Okay, this is another miscellaneous drug, all right? This is a form of targeted therapy. Okay? So this is not technically a chemotherapy. It is a targeted or immunotherapy, which means that it tries to just target the cancer cells. Okay. The best thing that it treats is leukemia. It stops an enzyme that causes leukemia. Okay. So you don't need to know the name of it, but there's an enzyme that helps the mutation or the replication continue of these blood cells. Okay, so by stopping the enzyme, we kind of stop the mutation or the cancer in general. Okay, doesn't need to go any deeper than that. Okay, there are many, 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 many adverse effects for this one. All right, so please just, I just tell you to do a med rec, which just means if you're giving Gleevec, please just compare their medications that they're taking with it. Okay. Also, the big adverse effects that are new, okay, would be fluid retention. So again, edema here. GI effects, which we're already familiar with, nausea, vomiting, diarrhea, constipation. It can cause hematological effects. Okay, so that could be anything to anemia, to thrombocytopenia, to bleeding, to blood clots. It could be anything along those lines. Okay. It can cause musculoskeletal pain. So kind of like pain in your muscles, pain in your bones, something along those lines. So that is important. And then it can cause dyspnea. Okay. Those would be the big adverse effects that I would want you to know. Okay. Otherwise, that's pretty much Gleevec, just trying to keep it as simple and straightforward as possible, okay? The next one is Lysodren or Mitotone, or Mitotan, sorry. So please know both names, but I probably will refer to it as Lysodren. This one treats adrenal gland cancer. Okay, adrenal gland cancer. If you don't remember where the adrenal gland is located, okay, if I have my kidney, okay, I know it's a beautiful kidney, all right. If I have my kidney, you have a little organ or gland right on top of it, okay, and that's for both kidneys. This right here would be your adrenal gland, okay, sits on top of the kidney. So this medication is literally treating cancer of the adrenal gland, okay. Cancer of the adrenal gland is very dangerous because the adrenal gland does a lot. It produces a lot of hormones that my body needs to work, especially steroids, like my corticosteroid, my aldosterone, things like that. It can also produce epinephrine, norepinephrine, my sex hormones. So if I just write that out really quick, just to kind of summarize that for you, if it wants to work, sorry. So basically it produces hormones, okay? Those hormones would be epinephrine, norepinephrine. It could produce sex hormones like my estrogen, my testosterone, my progesterone, okay? It can also make corticosteroids, all right, which is a huge steroid in terms of it has a lot to do with my body. It's my stress response hormone, okay? And it can make aldosterone, all right? Aldosterone is very important when it comes to fluid balance in the body, electrolyte balance in the body with my sodium and my okay. The interactions for this one, you don't need to know the mechanism of action for this one. I'm just going to try to keep it very simple because I know there's a ton of these, okay? But the interactions, all right, it's going to enhance CNS depression if you take it with other drugs that cause CNS depression. All right, so other drugs that cause CNS depression, let's make a list, okay? Medications that can cause CNS depression, okay, would possibly be, let's write out a huge list here, okay? Medications that can cause, again, CNS depression would be opioids, alcohol, benzodiazepines, which an example of a benzodiazepine would be Xanax or Valium or Ativan, okay? What else? My barbiturates. That would be like your phenobarbital, okay? Things like that, right? It could be, what are some other examples? Just off the top of my head, these would be the biggest ones. So if you were to mix this medication, so that would be, again, going back to my Lysodren, okay? If you were to mix this, which again treats adrenal gland cancer, with anything that causes CNS depression, which again would be something along the lines of these types of medications, okay? Opioids, alcohol, benzodiazepines, barbiturates, any kind of sedative, all right? It will cause extreme CNS depression, okay? And by CNS depression, I mean, so if you're not sure what that means, okay? If you do, I'm sorry, I'm gonna review it anyway. All right, that means my brain. Yes, my brain looks like a cloud. All right, I'm an artist, I promise. All right, so that means my brain and my spinal cord. Okay. The beginning of this all right here is going my coordination, my move, sorry, this app is not the best today. That means my coordination, my movements, right? What else? So let's write this out, right? So again, this is my CNS, my brain, and my nervous system. So if this is dropped, these medications can drop it, right? If I drop it, right, what I'm causing in my patient could potentially be, all right, goodness gracious, sorry, potentially be movement issues. So movement issues, loss of coordination. Okay, it could lead to drop in level of consciousness. It could lead to cognition, cognitive issues, which would be more like crying, fatigue, right? It could be like slow concentration. You can't think right. I usually try to compare CNS depression to if you are severely drunk. All right. If you are severely drunk, all right. Oh my goodness. If you are severely drunk, it will look about the same. Okay. So just to kind of put this into perspective, all right, if you take this Lysodren with any of these types of medications that already do this, all right, you're going to get this amplified. Okay, so all of these things right here. So the worst thing that can happen if you get severe CNS depression could literally be and my risk would be it would start off as other issues again, like the minor ones I talked about, loss of coordination, things like that, and then it could lead to coma, death, seizure. Okay. When I have warfarin or phenytoin, all right, phenytoin is a seizure medication if you don't remember. Okay, warfarin is a blood thinner, all right, which I know you all know. All right, if I take this Lysodren with either of these, okay, it's going to increase the excretion of warfarin and phenytoin from the body. What I mean by an increase in excretion, right? It's going to make the body clear the drug faster from the body. So what that's going to do is that it's going to get rid of the medication faster. So that it's not there as long to be effective or therapeutic as long. So what this means is that you may need higher doses of the warfarin or the phenytoin for it to last long enough to be therapeutic. Okay. And then if you take it with spironolactone, which again is my potassium sparing diuretic, you may kind of cancel out the effects of this cancer med. Okay. My severe or my really bad adverse effects here again is CNS depression. Okay. The CNS depression is going to be, again, why this interaction happens, okay? And then the other one I really want, that's really the only one that's super important, weakness, but the rest are kind of just, again, my common chemotherapy side effects, okay? Again, this one is oral, all right? It is not given parenterally, so that is something unique and different about that one, okay? Otherwise, it's pretty much everything that I want you to know about this drug, okay? This one right here, okay, octreotide or standostatin. Again, this one is not a statin either. All right. However, This is not a chemotherapy medication, but it is considered in this chapter because it does treat a condition that cancer causes. Okay. So if you have cancer of your adrenal gland, okay, you could get a condition just like kind of like a complication of the cancer called carcinoid crisis. Okay. What that does, okay, is it's going to cause a very rare and dangerous effect. We don't need to go super crazy into it, but it's basically going to cause hemodynamic instability. Okay. Hemodynamic instability. All right. So what hemodynamic instability is, okay, is going to be symptoms that are going to affect the lining of your heart, okay, your heart valves, your blood vessels. So it could cause fluctuations in blood pressure. It could cause confusion. All right. It could cause fluctuations in heart rate. It could affect perfusion, how much blood and oxygen is being pushed out to the rest of my body. It could affect your respiratory rate. It could affect your pulse ox. It could cause shortness of breath and dyspnea. Okay. It could cause issues with gas exchange, things like that. Okay. It could cause like issues with the valves, like mitral valve regurgitation or something like that, where you would have a murmur. Okay. And it could cause bronchospasms. So it could literally close your airway. All right. So that's what this carcinoid crisis does. Okay. When you have cancer of your adrenal gland, all right, or cancer of other hormone producing glands in your brain. So it could be either location. If you have cancer in those areas, again, a complication from that could be the carcinoid crisis, which is what we just talked about, the hemodynamic instability. And then this medication, octreotide, is used to treat it. Okay. So just including that as kind of a rare miscellaneous thing, but just kind of put that out there. This is just a summary slide. So we're going to go through past that. And then the last one here, okay, is going to be hormonal drugs. So these are going to be medications that are going to treat more reproductive cancer. So in women, that would be breast cancer, ovarian cancer, uterine cancer, vaginal cancer, cervical cancer. For men, that would be more prostate cancer, testicular cancer. Still could be breast cancer. Some men do get that, okay? So these types of hormonal drugs can treat those reproductive types of cancer, okay? The way that these work, okay, is a lot of these reproductive types of cancers actually feed off of my sex hormones. So let's say, for example, that I have ovarian cancer, okay? When my body gets flooding of estrogen, flooding of progesterone, it could speed up the growth of those cancer cells in my ovaries. So what this medication does is it tries to block those hormones from being able to land on the ovaries so that the cancer cells can't grow from it landing there and affecting it, because progesterone or estrogen is going to affect my ovaries in general. So if I stop the estrogen, progesterone from landing on the ovaries, it will also not affect the cancer cells that are being fed from it, okay? Which will then, when they do get fed from it, it accelerates the growth. So it'll help hopefully decrease the growth, okay? So that be your mechanism of action here, okay? All right, and like I said, if that doesn't make sense, please email me or come to tutoring. I will be able to answer that better. But let me just reiterate one more time, just in case it doesn't make sense. Again, if I have, like, let's say again, ovarian cancer, those cancer cells in my ovaries, they like, let's say, estrogen. Estrogen is kind of like food to them, okay? So whenever estrogen affects my ovaries, it also affects the cancer cells because they're in the ovaries, right? And it kind of, again, is like food to them. It's going to make them grow faster. So if I can stop the estrogen from even coming to the ovaries, it's not going to give the cancer cells that food. It's not going to feed them, okay? Able to make them grow more. All right. So hopefully that makes sense. Examples of these medications are the ones that I want you to know, all right, are going to be aromatase inhibitors, okay? The one I want you to know is anastrozole, okay? You don't need to know which ones they treat. These are, I just kind of giving you the list of them, okay? I just going to keep it simple. You need to know selective estrogen receptor modulators, and I want you to know tamoxifen. Okay, this is the class of the hormonal drug and then the name, okay? This is the class, this is the name, okay? I do need you to know progestins. Then the name, that hydroxyprogesterone, okay? Let me see. And then just know, I'm just trying to double check that there wasn't any other ones I needed you to know. And then just know this last one, anti-neoplastic hormone, estramucin, okay? These are the ones I need you to know for the exam, okay? These are going to be the ones that you see most often, okay? And then I do need to know the adverse effects that these can cause. They can cause vasodilation, okay, which can lower my blood pressure, reduce perfusion. All right, it can cause also hypertension. So it can cause vasodilation, but it can also cause fluctuations in my blood pressure. So just be aware of that, okay? These can also cause kind of like menopausal symptoms in a woman. So that would be more like your hot flashes. I'm not going to highlight these because, again, there's a lot of them, but hot flashes, mood swings, weight gain, okay, menstruation changes. In a male, it could cause gynecomastia, okay, which is male breast growth. It can cause difficulty breast tenderness, cause anorexia, all right, and it can cause effects. Otherwise, this is pretty much all that I want you to know from this one, okay? And then for these nursing implications, please just read through these. Extravasation, again, is when these medications are vesicant. Okay, so please just read through this. And then again, specific administration guidelines, we said that before. All right, please monitor the effects of bone marrow suppression. So that would be monitoring platelet levels, red blood cell levels, and white blood cell levels. Okay, and knowing that you may need to put your patient on fall precautions, bleeding precautions, and potentially neutropenic precautions. Okay. And then please monitor for cancer emergencies, all right, which would be toxicities, bleeding, other types of allergic reactions, infections, things like that. Okay. So that is it for chapter 46. So basically, that is it for both chapters. I will be posting this video. If you have questions, concerns, please let me know. Again, I apologize for the tech errors, tech issues. If I could have stopped them, I would have. But again, sorry, we had 2 storms in 2 days. And I guess my Wi-Fi is not happy. So hopefully, again, when you get this, it helps. If not, please let me know. All right. And I'm going to stop the recording. So thank you for your patience. Okay.